So let me discuss the very important topic, that is the immunomodulators. Now within this immunomodulators, I will take up the individual drugs. I'll tell you how those particular drugs are causing immunomodulation and where are they indicated. Now first and foremost, the very important drugs in this particular group of immunomodulators is your glucocorticoids. Right, it is your glucocorticoids. Now if you take these glucocorticoids, remember these are one of the most commonly used immunosuppressant drugs. Right, these are the most commonly used immunosuppressant drugs. Now if you take the mechanism of action of these drugs, right, so they are causing immunosuppression. Now if you see the mechanism of action of this particular glucocorticoids, remember as such they are immunosuppressant drugs. And how do they act? Remember, they act by inhibiting the production of the inflammatory mediators or immune mediators. So remember, they will cause inhibition of production of the prostaglandins, right? They will cause the inhibition of the production of leukotrienes, and they will cause the inhibition of the production of histamine, right? They will cause the inhibition of the production of the bradykinin and as well as the platelet activating factor. So this is the mechanism of action of these glucocorticoids. Now the other important thing is this particular glucocorticoids will also diminish the chemotactic activity of the neutrophils and as well as monocytes. So these drugs will also reduce, right, will also reduce the chemotactic activity, right, chemotactic activity of the neutrophils and as well as the monocytes, right, as well as the monocytes. Now you see this word, the chemotactic activity. Now what do you mean by this word chemotactic activity? The chemotactic activity means this particular inflammatory cells from the blood vessel, they will reach the site of inflammation, that is called as chemotaxis. And by reaching the site of inflammation, these inflammatory cells will release the inflammatory mediators. And what is your corticosteroids doing? They are reducing the chemotactic activity of the inflammatory cells, and thereby they does not reach to the site of the inflammation, and thereby there is no release of the inflammatory mediators. Next, now if you take these glucocorticoids, they also cause the sequestration of the lymphocytes in the lymphoid tissue, resulting in lymphopenia, right? They will also cause sequestration of, right, they will also cause the sequestration of lymphocytes in lymphoid tissue. Now by causing the sequestration of the lymphocytes in the lymphoid tissue, they will result in lymphopenia, right? They will have this lymphopenia. Next, now remember these glucocorticoids, they will inhibit the interleukins. So by inhibiting the interleukin 1 production, these can cause decrease in interleukin 2 and as well as the interferon gamma production. So remember glucocorticoids will inhibit the interleukin 1 production. So by inhibiting the interleukin 1 production, these glucocorticoids can decrease the interleukin 2 production and as well as interferon gamma production, right, interferon gamma production. Now you take these glucocorticoids, remember continuous administration of glucocorticoids can increase the catabolism of an immunoglobulin, that is IgG. So continuous administration, right, continuous administration of these glucocorticoids can increase, right, can increase the catabolism of the immunoglobulin, that is IgG. And let me tell you the indications of glucocorticoids. Remember, these are used as the first line immunosuppressive drugs for solid organ as well as the hematological stem cell transplant recipients, right? So these are considered as right? These are considered as the first line immunosuppressive drugs, right? These are considered as the first line immunosuppressive drugs for both solid organ and as well as the hematological stem cell transplant recipients. Solid organ as well as the hematological stem cell transplant recipients. Okay. So in both these clinical disorders, like these drugs are used as first line drugs. Now apart from this, the immunosuppressive activity in case of the solid organ plus the hematological stem cell transplant recipients, remember these glucocorticoids, they are also used for the treatment of graft versus host disease. That is, an individual has acquired a graft. In order to prevent the immune activity against that particular graft, the glucocorticoids are used. And they are also used in the treatment of immune thrombocytopenic purpura, used in the treatment of rheumatoid arthritis, and used in the treatment of bronchial asthma, right? So these are also used in the treatment of graft versus host disease, used in the treatment of rheumatoid arthritis. So rheumatoid arthritis, remember, this is one of the immunologically mediated or immune mediated arthritis, right? And also used in the treatment of immune thrombocytopenic purpura, and apart from this, they are also used in case of bronchial asthma. So this is about your glucocorticoids. So let me shortly revise about the glucocorticoids being used as immunomodulators. Remember, these are the most commonly used immunosuppressant drugs, and they act by inhibiting the production of the prostaglandins, leukotrienes, histamines, bradykinin, and platelet activating factor. And not only that, these drugs will also reduce the chemotactic activity of neutrophils and as well as monocytes. And remember, glucocorticoids, they will cause the sequestration of the lymphocytes in the lymphoid tissue, resulting in lymphopenia. And by inhibiting the interleukin-1 production, these drugs, they cause decrease in interleukin-2 and as well as interferon gamma production. And continuous administration of these glucocorticoids can increase the catabolism of the IgG. And remember, these are used as the first line immunosuppressive drugs for solid organ and as well as hematological stem cell transplant recipients. And not only that, these are also used for the treatment of graft versus host disease, also used in the treatment of immune thrombocytopenic purpura, rheumatoid arthritis, and as well as bronchial asthma. Next, let me discuss the other immunomodulatory group of drugs, that is calcineurin inhibitors. Now let me discuss about the calcineurin inhibitors. So if you take this calcineurin inhibitors, let me tell you what is the mechanism of action of these drugs. So before that, if you see the drugs in this calcineurin inhibitors, like we have cyclosporin and the other drug is tacrolimus. So both of these drugs, they will inhibit this calcineurin. Now let me tell you what exactly is the importance of the calcineurin. Remember, this particular substance, that is calcineurin, right? This particular substance, calcineurin, it is required for the activation of the NFAT, right? It is required for the activation of NFAT. Now what does this NFAT stands for? It is nuclear factor of activated T cell, right? Nuclear factor of activated T cell. That is what is called as NFAT. Now remember, by activating the NFAT, so calcineurin is required for the activation of NFAT. Now once the NFAT is activated, in turn it increases the transcription of interleukin-2 by activated T cells. So the activated NFAT, what it will do is, it increases, right? It increases the transcription of interleukin-2. Right, it increases the transcription of interleukin-2 by activated T cells. Alright, by activated T cells. Now, so if calcineurin is there, then there is increased production of your interleukin-2. Now, whenever you give this cyclosporin or tacrolimus, it is also called FK506. Alright, so this particular drugs, that is cyclosporin and as well as tacrolimus, what they will do is, they will inhibit the activation of the NFAT. right? They will inhibit the activation of the NFAT by binding to the immunophilins. I'll tell you what are immunophilins. So what these particular two drugs will do is they will inhibit, right? They will inhibit the activation of the NFAT by binding to, right? By binding to immunophilins. Now, if you see these immunophilins, right? If you take these immunophilins, you take the cyclosporin. Cyclosporin will bind to the immunophilin called cyclophilin, and tacrolimus will bind to the immunophilin, that is FKBP. Okay, cyclosporin, it will bind to the immunophilin which is called as cyclophilin, whereas you take the tacrolimus, it will bind to the immunophilin which is called as FKBP. Alright, now what is the net result? Cyclosporin and tacrolimus, they are binding to the immunophilins. The net result of administration of the cyclophilin and tacrolimus is the inhibition of the gene transcription of the interleukin 2. Okay, so the net result of administration of these drugs is, right, net result of administration of these drugs is inhibition of, right, inhibition of the gene transcription of interleukin 2. Now, so basically what are they doing? They are causing immunomodulation by suppressing the formation of interleukin 2. Now, where are these drugs used? Remember, these are used as immunosuppressive agents for organ transplantation, right? For organ transplantation, these drugs are used, and these drugs are also used in case of graft versus host disease, and they are also used in case of certain autoimmune diseases, right? Also used in case of the autoimmune diseases like rheumatoid arthritis, right? Like rheumatoid arthritis and as well as psoriasis. Now, you take the adverse effects associated with these drugs, right? You take the adverse effects associated with these drugs. This particular cyclosporin, it can cause nephrotoxicity and as well as the hepatotoxicity, right? It will cause renal impairment and as well as hepatic impairment. So apart from renal impairment and as well as liver impairment, these drugs, it will increase, they will increase the blood pressure of the individual, wherein the individual will have hypertension, and because of the renal impairment, these drugs can cause hyperkalemia because the potassium has to be excreted through the kidney, and apart from this, because of the renal failure, there can be hyperlipidemia as well, because in patients with the renal failure, there is inactivation of the lipoprotein lipase, and thereby the lipids are not being degraded. There will be hyperlipidemia, and because of the renal failure, there can be also increase in the uric acid, and right, so hyperuricemia, because the uric acid is also the substance which has to be excreted through the kidney, and these drugs will also cause the hyperglycemia. And if you take the other cosmetic problem, that is hirsutism, right, where there is excessive growth of the body hair. And apart from this, remember, these particular drugs, that is the cyclosporin, it will also cause gum hyperplasia, right? It will also cause gum hyperplasia. Now, if you take this particular gum hyperplasia, it is also associated with one of the anti-epileptic drug, that is phenytoin, right? Next, apart from nephrotoxicity and hepatotoxicity, cyclosporin, it will also cause the neurotoxicity, right? It will also cause the neurotoxicity. Now, so after having discussed about this particular adverse effects, remember the incidence of hyperglycemia, right? Incidence of this particular hyperglycemia, wherein there is increase in the glucose, Incidence of hyperglycemia and as well as neurotoxicity are more with tacrolimus compared to that of cyclosporin, right? This is an important point that you should remember. So point what you should remember is the incidence of, right, the incidence of the hyperglycemia and as well as the neurotoxicity. It is more with the tacrolimus compared to that of cyclosporin, right? It is more with the tacrolimus compared to that of cyclosporin. Whereas you take the other adverse effects like hirsutism, where there is excess growth of the body hair, and the adverse effects like gum hyperplasia, adverse effects like hyperuricemia and as well as the hyperlipidemia. If you take these adverse effects, these are not caused by tacrolimus, they are caused by your cyclosporin. So remember, the hirsutism, hyperlipidemia, hyperuricemia, gum hyperplasia, they are mainly caused by your cyclosporin but not tacrolimus. Alright, let me shortly revise about the calcineurin inhibitors here. Remember, calcineurin inhibitors we have, that is cyclosporin and tacrolimus. The calcineurin, it is required for the activation of the NFAT, that is nuclear factor of activated T cells, which in turn increases the transcription of interleukin 2 by activated T cells. And this cyclosporin and tacrolimus, they will inhibit the activation of NFAT by binding to the immunophilins, that is cyclosporin, it will bind to the cyclophilin, and tacrolimus, it will bind to FKBP. And the net result of administration of cyclosporin and tacrolimus is the inhibition of the gene transcription of the interleukin 2. Now if you take the uses of these drugs, now net result of the administration of these drugs is these drugs will cause the inhibition of the gene transcription of interleukin 2. Now where are these drugs used? They are used as immunosuppressive agents for organ transplantation, graft versus host disease, and some autoimmune disease like rheumatoid arthritis and psoriasis. And if you take the adverse effects of very particularly the cyclosporin, it can cause nephrotoxicity, hepatotoxicity, hypertension, hyperkalemia, hyperlipidemia, hyperuricemia, hyperglycemia, hirsutism, and gum hyperplasia, neurotoxicity. Right. And if you take the incidence of the hyperglycemia, alright, the incidence of the hyperglycemia and as well as the neurotoxicity are more with the tacrolimus compared to that of cyclosporin. Whereas hirsutism, gum hyperplasia, hyperuricemia and hyperlipidemia, they are not caused by tacrolimus, they are caused by only cyclosporin. Now if you take some important points about this calcineurin inhibitors, remember, if you take the comparison between cyclosporin and tacrolimus, tacrolimus is more potent than cyclosporin. Alright, tacrolimus, they are more potent compared to that of cyclosporin. Now as such, if you take tacrolimus, remember tacrolimus, it is a macrolide antibiotic, right? It is a macrolide antibiotic. Now what is the major limitation of these particular calcineurin inhibitors? Remember, the major limitation is the nephrotoxicity. Nephrotoxicity is a major indication for cessation or modification of the cyclosporin therapy, right? So this nephrotoxicity, this is the major limitation of this particular cyclosporin. Next, now you take the other adverse effects, that is like hypertension. Remember, hypertension, it occurs in 50% of renal transplant and almost all cardiac transplant recipients, right? So if you take this hypertension, it occurs in almost 50% of renal transplant, right? Used in case of 50% of renal transplant and almost all cardiac transplant recipients. Alright, so this is about your hypertension associated with the calcineurin inhibitors. Next, now we have a substance which is called as the sirolimus, right? We have a drug called sirolimus. What this sirolimus will do is, remember, this sirolimus will aggravate the cyclosporin induced the renal dysfunction. Right, it will aggravate the cyclosporin induced renal dysfunction, whereas cyclosporin increases the sirolimus induced hyperlipidemia and as well as myelosuppression. So both of these drugs, they have drug-drug interaction. So remember, this particular drug, that is sirolimus, it will aggravate, right, it will aggravate the cyclosporin induced, right, cyclosporin induced renal dysfunction, whereas you take cyclosporin as such, right, you take cyclosporin as such, whereas cyclosporin, right, cyclosporin, it increases, right, it increases the sirolimus induced hyperlipidemia and as well as myelosuppression. Right, sirolimus induced hyperlipidemia and myelosuppression. So these are some of the important points what you need to remember regarding the calcineurin inhibitors. So remember, regarding the potency wise, tacrolimus is more potent compared to that of cyclosporin, and tacrolimus, it is as such is a macrolide antibiotic, and the major limitation of cyclosporin therapy is the nephrotoxicity. So nephrotoxicity is a major indication for cessation or modification of cyclosporin therapy. And you take hypertension. Hypertension occurs in 50% of renal transplant and almost all cardiac transplant recipients. And this particular cyclosporin, it has drug-drug interaction with sirolimus. Sirolimus, it aggravates the cyclosporin induced renal dysfunction, whereas cyclosporin increases the sirolimus induced the hyperlipidemia and as well as myelosuppression.